Hello everyone, and welcome to our 12th week in our course on drugs and behavior. This week we'll be talking about the hallucinogens. Now there are a lot of different compounds that belong to this category, and we're only going to have a chance to go over a few of them, those that are the most famous or the most important, that have the most history, for example. But there are a lot of them, and as you'll see, categorizing these things has been a little bit difficult over history. But we will define our categorization as part of our unit on hallucinogens. Uh, so we'll classify them. As we'll see, there are a couple different ways that we're going to classify them to get them down into specific categories. And then we'll talk about how hallucinogens work. And in particular, we'll spend some more time on LSD, which is one of the most famous hallucinogens. And so we'll talk about how LSD works. And then as we move on to other categories, we'll see that not only do the effects differ, but also the mechanism of action differs. And then we'll wrap up this unit by looking at the relationship between hallucinogens and society. And hallucinogens occupy sort of a unique space in our history. Uh, and of course, they carry with them a unique history of research, as well as trends in usage. They're not as popular now as they were during the 60s, for example, but it's not to say that they don't get used, and there aren't new ones that didn't really exist in the 60s, or at least weren't popular. So we'll talk about society's relationship with hallucinogens as well. In particular, in this session, we'll go over our classification, and that's going to frame this whole unit, both this session and next session, because there are so many hallucinogens, and the classification is a little bit difficult, but we'll go over it. We'll also learn about the chemistry of these different substances. That's part of the classification scheme. And also it explains why hallucinogens, especially LSD, which we'll focus on today, why these drugs have the effects they do. It's not completely understood, as is the case for most drugs, but we do know a little bit, so we'll go over that. And then we'll go over the history of LSD. Now, LSD, despite being so famous, doesn't have that long a history because it's synthetic. So we'll go over that as well. Okay, so last week's discussion questions. Obviously, we were talking about marijuana last week, and the first topic was about the age for recreational marijuana use. And the question is, it's currently 21 in Colorado. Is that the right age? Should it be lower? Should it be higher? And there are pros and cons to any of the popular ages that can be proposed. So some people like the age of 21 where it is. That is the age at which you can legally drink alcohol. And so it makes sense that another psychoactive substance, marijuana, would have the same age attached to it. Some prefer the age of 18, saying, well, you can vote at 18, you can enlist in the military at 18, you are legally counted as an adult at 18, so you should be able to make the choice to use marijuana or not. And some people prefer an older setting, so age 25, for example. And the idea there is that your brain is still developing at age 18 and even at age 21, especially your prefrontal cortex. And so the older one is, if one starts using marijuana, the less effect it tends to have in terms of long-term cognitive effects. And so the 25 proponents say that is an appropriate age given the developmental time course of the brain. And again, there are obviously arguments to be made at each age. There's nothing magic about age 21. It is in fact somewhat arbitrary, but it is the legal drinking age. And age 18 carries some privileges with it, but there are other ages that carry privileges as well. For instance, you can often drive at age 16. You can often drink alcohol at age 21, and there are public offices that the age limit is 25 or 30 or 35. So there are a number of different ages that are milestones of one sort or another. So whether 18 is the one milestone we should consider is a bit arbitrary as well. And of course, one important distinction here is with regard to recreational versus medical marijuana. And so with medical marijuana, you have a physician, you have a trained medical professional who knows about things like dosages, interactions, long-term effects. And this is information that your average recreational user does not have. And so there is not an age limit in that sense for medical use because it's entrusted to the physician. Now, again, recreational use is up for debate. And one thing to consider here is the effect of precedence. So again, age 21 for drinking is somewhat arbitrary. Uh, so there's nothing rational about choosing age 21. And also, if 21 is the drinking age, do we want it to also be the age for marijuana use? Do we want to throw both of those substances at a person at once, so to speak? And this is also a good argument for why we don't have the drinking age as the same as the age at which one gets a driver's license. You don't want people that are inexperienced with both of those things combining them when they're in it when they don't have any knowledge of either one. And so that's another argument as to why, in terms of why we might not want age 21 to be the age for marijuana use. And for something like drinking, suppose we decided that 21 was not the appropriate age, that perhaps 25 would be a more responsible age. Now, there would be a lot of disappointed 20-year-olds. And there are also a lot of legislation, there's a lot of legislation in place dealing with age 21. So to suddenly overturn that or change it, you're dealing with a lot of inertia there. And so the question is, as a society, how much do we want to fight that fight? If we think, in terms of evidence-based research, that there's a more appropriate choice for the drinking age or the age for marijuana use, do we want to spend the effort changing the mind of society and changing things like legislation? So that's an open question. The other question for discussion was about designer drugs. And here we're really talking about synthetic cannabinoids. So substances that are similar to the psychoactive components of marijuana, but aren't quite chemically the same. And one common position here is the idea that research and education are both important. Education so that the public is aware of what we know about synthetic cannabinoids, but also what we don't know, which is quite a bit. And then research so that we can understand how these chemicals work. What do they do to the brain, both short-term and long-term? Again, they're chemically similar to the ingredients in marijuana, but they're not identical. And the hard thing here is that our ability to synthesize new compounds easily outpaces our ability to research them and look at what they do to the brain. And they certainly outpace our ability to legislate these substances. So our laws historically lag well behind the development of new drugs. So we're always trying to keep up there. One thing to keep in mind here, though, is that many people will say that they would take marijuana before they would take the synthetic cannabinoids. And while that's a good idea, again, the synthetic cannabinoids we know less about, and they've been shown to have some dangerous side effects. It's not because cannabis is a naturally occurring substance. People will say, oh, well, it's found in nature, or it's a more natural drug, so I prefer that. And that's not a very good argument. It's what's called the appeal to nature, which is a sort of logical fallacy. Just because something is found in nature doesn't mean it's necessarily good for you. It doesn't mean that it's better than the synthetic version. If you synthesize the same compounds, chemically they're identical. There's no reason to prefer one over the other. So just because something is natural doesn't mean that it's better. And so we'll come back to this topic when we get to dietary supplements, that just because a chemical comes from a plant doesn't mean it's a good thing to take. It may do nothing, or it may actually be harmful. So keep that in mind. Okay, that is it for discussion from last week. Keep in mind that your second paper is due this week. In fact, it's due this Friday night. So I'm sure many of you have started your papers already. If you haven't, it is time to get started. And with that, we'll go over an overview here. So this is our classification scheme. So this week is about the hallucinogens. So how do we classify them? There are a lot of different compounds. First we can classify them by the effect they have. And all the hallucinogens, to some degree, distort perception of or access to a reality. Uh, the first category we'll talk about, and the category to which LSD belongs, uh, is called the Fantastica. And we'll go over why that is in a minute. So your book uh, makes a binary distinction between Fantastica and deliriance. And this is an unusual scheme, so I've gone with the more typical breakdown, which is the Fantastica, the dissociatives, and the deliriants. We'll go over what those two categories mean. Certainly next session, we'll go over briefly here. But first, we'll talk about the Fantastica a little bit more. So after you've categorized a hallucinogen as belonging to the Fantastica, then it's subcategorized by structure. There are what are called the indole hallucinogens and the catechol hallucinogens. And these are references to their chemical structure. So indole is a chemical group, catechol is a chemical group, and so you can differentiate the two based on what they look like chemically. So the indole hallucinogens contain hallucinogens like LSD, like psilocybin, which comes from what are called magic mushrooms, from DMT. And then the catechol hallucinogens are things like mescaline and also the amphetamine derivatives. So things like MDMA, ecstasy. The dissociatives are drugs like PCP, ketamine, and we'll go over all of these next session. And then finally you have the deliriants, and your book has that category. It includes PCP and ketamine as deliriants, and that's not typically done, so I've departed from that. So keep that difference in mind. But the deliriants are largely plant or fungus based. There's atropine, there's Amanita muscaria, which is a mushroom. You can also get certain deliriants from poisonous animals, but we're not going to go over that as much because they're just frankly not that popular. So that's our scheme, and it looks a little complex, but really it's just two categorizations. There's the Fantastica, dissociatives, and deliriants, so that's sort of upper tier, and then the indole and catechol hallucinogens, and then everything belongs to one of those groups. So we'll talk about the Fantastica, and what defines a member of the Fantastica is it creates a world of fantasy, which is, you can sort of tell from the name. So this is not as disruptive an experience usually. It's not a break from reality. Certain other hallucinogens can recreate many of the symptoms of psychosis where the person doesn't really have access to reality. Here, the Fantastica, the tendency is for these experiences to modify existing perception. So you still have access to the world, you can interact with people, but these drugs alter sensory perception. And now, higher and higher, the higher the dose, the larger the distance from reality tends to be. But at the level of the effective dose, the person is still very much in touch with reality, as their perception is altered. Now, there are other words that describe this category that have historically been used, things like psychedelics, which of course now we associate with multicolored visual presentations. But psychedelic originally meant this class of drugs. It was thought that they would help you peer into the mind. That's what the word psychedelic means. And that's probably too complimentary a term, as your book points out. There's really no evidence that it helps with things like creativity or that it helps you access the subconscious. At least in the Freudian sense, there's not much evidence the Freudian subconscious actually exists. So the mind's enriching benefits of hallucinogens are sort of exaggerated by the term psychedelics. There's also the psychotomimetic term, which means it mimics the symptoms of psychosis. And this is perhaps a bit too pejorative. That is, it has a negative connotation, and really, this class of hallucinogens doesn't mimic psychosis all that well. So as mentioned in the last slide, there are two big types of Fantastica. There are the indole hallucinogens. The indole is a chemical group shown here. So we see a 6-ring or a 6-carbon ring connected to a 5-element ring. Here, one of the atoms is nitrogen. Um, but this is uh, sort of the core of neurotransmitters like serotonin. And so it's no surprise that these hallucinogens seem to act through the serotonin system. So here's serotonin right here. We can see that same structure. We have those 2 rings that are connected to one another. And then you also have the catechol hallucinogens. And catechol is, again, a chemical group that looks like this. And if you have a very good visual memory, you'll notice this molecule looks like some of the amphetamines and methamphetamines. So this is a dopamine-like neurotransmitter. It turns out the catecholamine neurotransmitters include things like dopamine, norepinephrine, and epinephrine or adrenaline, which we don't talk about as much because it's not a key neurotransmitter. But there are several neurotransmitters that do have this chemical element to them, that have this 6-ring structure. Okay, so our topic today is going to center around LSD, which is D-lysergic acid diethylamide. We can just call it LSD. So it's synthetic. It does not occur naturally. As we'll see, many of the compounds we'll talk about in this unit are naturally occurring. Certainly the deliriants, but also some of the fantastica. The dissociatives are synthetic also. But LSD was first synthesized by a man named Albert Hofmann, who died somewhat recently. But he synthesized it, and at the time, it was not an uncommon convention for the scientists developing a new molecule to taste it, to try it out themselves. This is, of course, a dangerous practice, but this was true not just for drugs, but for all sorts of compounds. So LSD is an indole hallucinogen. It has that indole group on it, which means it's structurally similar to serotonin. So here on the bottom left is the figure from your book that shows what LSD looks like chemically. Now, of course, there's a lot of extra structure to it, but it's thought that LSD acts on serotonin because that bottommost portion of the molecule is similar to serotonin structure. So serotonin is a neurotransmitter, as we know. It's involved in mood and temperature regulation, but it has a lot of different receptors. These receptors have subtypes. So 5-HT is one of the chemical names for serotonin, and so the receptors for serotonin are named 5-HT and then a number and a letter designation. Now LSD seems to be particularly involved, interactive with the 5-HT2A receptor. And this is a receptor that's found throughout the brain, but mainly in the cerebral cortex. So here on the right is from a research paper that is imaging where the 5-HT2A receptor is. And so the bright portions are where the receptor is most concentrated. So we see there's not much in the thalamus, the caudate, and the basal ganglia don't really have this receptor, but the cortex has it, and especially the visual cortex. This is thought to be why LSD affects visual perception, because it's interacting with those serotonin receptors. So what does LSD do? So first, a little bit about how it's absorbed and eliminated. It's usually ingested. So LSD, as we'll see, has a very small effective dose. It doesn't take very much at all. It's easily absorbed, and so it's often ingested in the form of little pieces of blotter paper that have been infused with LSD. Just a tiny little square with some LSD on it is enough for it to be the effective dose. It's very uncommon to take LSD any other way. It can also be absorbed by contact. This is actually how Hoffman first experienced this. He touched the substance. and it was absorbed through the skin. And because it doesn't take very much to be effective, you can actually absorb enough through the skin to be effective. LSD is eventually metabolized by the liver, as so many drugs are, but it lasts for a while. It's not like nicotine or even like alcohol, where the half-life is relatively short. LSD has a half-life of 3 hours, and so this corresponds to how long the experience lasts. The experience can often be longer than that, especially the higher dose is taken. Tolerance actually builds up fairly quickly to LSD. So after only a few uses, the person can be tolerant of it. The effects will be less for the same dosage. And it also exhibits cross-tolerance, which is a concept we talked about a while ago, where if someone uses LSD repeatedly, then they will be less sensitive to other hallucinogens as well, things like psilocybin. As I mentioned, LSD has a very small effective dose. Usually, if you have a small effective dose, it means that it's easy to make a mistake and take a fatal or harmful overdose. But actually, there have been no recorded fatal overdoses on LSD in humans. It has been shown in mice, but the amount of LSD required to kill the mouse is about 400 times the effective dose. So it's more than any person would ever intentionally take. And still in humans, there have been no reports of fatal overdoses based on LSD alone. Now, of course, the behavioral effects of LSD can cause someone to put themselves in danger. They can think they can fly, for example, or they can be impaired if they're driving. But LSD itself has not caused a fatal incident. So this usually takes the onset of the effects are within 20 minutes. So it's relatively quick acting, especially for something ingested. Remember, when marijuana is ingested, it takes about 90 minutes to take effect. But here, the onset is within 20 minutes or so, and it can last for several hours. And again, this depends on how much is taken. So what are the effects of LSD? Well, first, it's a sympathomimetic. What does that mean? Well, it means it acts like it's activating the sympathetic nervous system. So you get things like pupil dilation. And that's a famous sign of hallucinogen intake. You also get increase in heart rate, increase in body temperature. The most notable cognitive effect is the modification of visual perception. And so these are called hallucinogens because they generate, in sufficient doses, they will generate hallucinations. But the more common effect is just a modification of existing perception. So it's not a hallucination in the sense that it's something that's actually there. It's not creating something out of nothing. So in schizophrenia, patients often suffer auditory hallucinations. They hear voices that aren't there. Here, visual perception is really modified. You're not seeing something that isn't there, but it'll become more colorful or it'll seem like it's moving. So it's more a modification of visual perception. You also get the effect of synesthesia, which is a melding of the senses, sort of a confusion of one sense with another. So you'll have sounds that have visual quality. It'll seem like you can see the sound that's being produced. And synesthesia is also something that happens in people who haven't taken LSD. There are people who are chronically synesthetic. And so they'll report things like numbers or letters being a certain color when in fact they're printed in black and white, or that they have a certain taste associated with them. So they'll say that the number 4 tastes salty, even though obviously they're just looking at the number 4. So with LSD, you get a similar effect. You get a melding of the senses, and that is another one of the hallmarks of the LSD experience. If you have what is known as a bad trip, then you can get negative side effects like anxiety and panic. And of course, this is exacerbated, is enhanced by the sympathomimetic qualities. Emotions can be enhanced. your arousal state is higher, heart rate is higher, so it's not surprising that this would be associated with a feeling of panic or anxiety. And if too much has been ingested, some of the effects of LSD can be diminished or eliminated using neuroleptics, which is a class of drugs we talked about a few weeks ago, and that's used to treat psychosis, usually schizophrenia. Uh, and again, LSD, the effects of LSD are not synonymous with psychosis, but it is somewhat telling that you can reverse some of the effects of LSD with antipsychotics or neuroleptics. Chronic use of LSD doesn't seem to have that many effects. There are reports of what are called LSD flashbacks, which is probably a term we've all heard of. And this happens when a person experiences a distortion in visual perception or synesthesia or any of the effects of LSD without actually having taken the drug. It should be noted that this is not the result of LSD being absorbed by fatty tissue, for example, and then when that tissue is metabolized, that LSD is released. That's not what happens. There is no LSD in the system when these flashbacks occur. Nevertheless, it's been very hard to recreate these so-called flashbacks, and especially in a laboratory setting. And so it's thought to be not that common and very hard to reproduce. So we're all aware of this as a cultural phenomenon. We're all aware of the term flashback, but it seems to be very rare, and it's been very hard to pin down exactly what the person means by flashback. One of the possible causes is just that the experience itself has been remembered. And so just like a smell or the sight of something or seeing someone's face can remind us of an experience, the LSD experience can be cued by normal things in our everyday life. Again, these hallucinogens have sometimes been called psychedelics, the idea that you would have special insight. But there's really no evidence that it increases creativity in any way. So it's not the person has special insight into the universe or even themselves necessarily. One thing LSD has been thought to be used for is dependence, and especially alcohol dependence. It has been shown that LSD can reduce the amount of alcohol intake by problem drinkers. But this is a little bit controversial, a little bit unclear as to how effective it is, mainly because there hasn't been as much research on hallucinogens as there has been on other drugs. And some, it's not fair to say there's been none, but there just hasn't been as much work on this because hallucinogens were sort of frowned upon over the last few decades. In any event, well, this is a topic we'll come back to next time when we look at some other hallucinogens and what they might be used as treatment for. So a quick word on the history of LSD. So LSD, Hoffman first derived the chemical from what are called ergot alkaloids. Alkaloid is a chemical designation. Ergot is actually a fungus that's found on grain, and we see it here on the right. So it's just a little oblong bit of fungus that stays on the grains of particularly rye, but also wheat, for example. And this is often, or at least historically, has been accidentally ingested when the wheat is harvested, or the rye is harvested, ground up and used to make bread or any other product that grain is used for. But ergot contains these ergot alkaloids, and if consumed in sufficient quantity, these alkaloids produce convulsions, can produce psychosis and hallucinations. So a lot of similar symptoms to what LSD does. So LSD is chemically very similar, even though LSD itself is not contained in ergot. Interestingly, this has possibly had a big effect on history. So it's been theorized, not for sure, but theorized that incidents of so-called witchcraft, especially the Salem witch trials, may have been spawned by ingestion of ergot. That if a village harvested their grain and ergot was ground up with grain and then ingested, uh, you get you also get painful gangrene, so um, eventual loss of limbs. But you get these psychological effects as well, and it was thought that perhaps witches were responsible. We'll get back to witchcraft next time. There's another class of hallucinogens that may be involved in the idea of witchcraft. Um, and ergot alkaloids have been uh, possibly theorized to have been involved in other incidents of mass hysteria. So if you look at so-called dancing mania in the medieval era, or even what was called the Great Fever of the French Revolution, if you have a lot of people all at once taking these ergot alkaloids in, then you've got a large population that is hallucinating. And so it's thought that many historical events might have been influenced by ergot alkaloids, especially when grain was scarce. If there was a famine, people had to turn to this grain that wasn't as pure. More recently, and with LSD in particular, there was an unfortunate era where LSD was used in secret government slash military research, used by the military, used by the CIA, and this brought up the idea of ethics in research. Of course, a lot of research has been done ethically before this, but every now and again there's a giant breach of ethics, and this reminds us how important it is to treat people ethically in medical research. And so in this case, people were given LSD, often without their knowledge uh, and without their consent. And so many people thought they were losing their minds because they started experiencing the effects of LSD without being aware that they were taking a drug. And this was done by the military mainly to look at it as an interrogation technique, um, and to see if there's a possibility to train people who might be interrogated uh, so they can deal with the effects of LSD and not divulge sensitive information. But anyway, it was done without consent, done without awareness in most cases. Those that gave consent were actually singled out for being given massive doses or long-term doses of LSD, being given LSD for 100 days or more in a row. Um, so this is a big ethical breach and didn't really produce anything anyway, not that that would have justified it. Also, it highlights the importance of the effect of expectations. This is true for any drug, but especially the hallucinogens. Um, so the bad trip experience isn't dose dependent, um, and it's really thought to be environmental and about the expectations of the user. So if you have people being given hallucinogens and you're not allowing them, by not telling them, you're not allowing them to expect certain effects, there was a much higher incidence of anxiety and panic, because again, they didn't know they were on LSD. More recently, and this is getting into the 60s, you had recreational use of LSD, most famously by a Harvard professor, who was not a professor for long, named Timothy Leary, who many of you have probably heard of. And I mentioned Leary in our very first lecture. So again, this was a group of individuals that thought that hallucinogens could be used for spiritual or self-insight. And that's not a new idea, as we'll see. But Leary was a big proponent of LSD. And of course, from there, it became popular, especially among young people in the 60s. So again, we have this idea, this recurrence of the idea that drugs aren't universally bad. So LSD is not, you can't fatally overdose on it. But they're not universally good because they don't grant all the insights people think they do, and bad experiences are possible. So as always, it's a mixed bag. Okay, so that will do it for our unit on LSD and the beginning of the hallucinogens. Next time, we'll still look at hallucinogens, and we'll look at all the other hallucinogens. So we'll continue to look at the indole and catechol hallucinogens, and then we'll move on to the dissociatives and the deliriums. And then finally, we'll talk about the status of hallucinogens, both in terms of law and in terms of research, and also what the current trends are in terms of usage. So that will be next time, and I will see you then.